Hello, everybody. This is the third of our annual healthcare events at Cooper Parry. Sadly, the second one that has had to be virtual after our original one in Birmingham, which we could actually get people physically to. Let's keep fingers crossed that next year we'll all be able to physically get together. Today, we have two speakers. Firstly, Professor Martin Green, the Chief Executive of Care England. He has unfortunately couldn't actually be here this afternoon, so I recorded an interview with him and was sharing that. I had to tell you that I was recording the interview because I'm actually wearing different clothes this time. And secondly, we have Giles Johnson from CIL, the commercial diligence strategy consulting firm, to give some views about the marketplace, how investors are looking at it, and what is going to drive that over the next few years. So really topical subjects for most of us. We'll have questions and answers with Giles. So as he's speaking, please feel free to drop down questions, send them in, and we'll pick those up. And Laura from my team will be addressing that. So Steve, I'm going to ask you now to just sort of link us up with the discussion that I had with Martin Green.
Martin, thank you very much for joining us. Really appreciate your time. An incredibly busy year, second year of the pandemic now. So lots happening in the care sector. And as we're hosting this event, really wanted view from an expert, somebody who takes the temperature across the marketplace to share with our guests. So thank you very much, Martin Green. Can I kick off, Martin, by just asking about the pandemic? What's been the biggest effect you've seen?
Well, I think one of the things that's been really to the fore is how social care has been on the front line of the pandemic. And if you think back to when this pandemic started, I think one of the things that happened was that social care was very ignored. And then as we got a bit more into it, we began to realize that the people who were in social care services were at most risk. I think it's also shown that social care, and particularly social care staff, are absolutely amazing. They've shown professionalism. They've shown total commitment to the people they support. They've shown that they can do a range of things, particularly around administering drugs and things that were previously done by the NHS. And they've really stepped up to the plate, because at the start of the pandemic, the NHS withdrew from social care. So I think lots of things have come out of this pandemic, but not least a better recognition of the role of social care and the amazing nature of social care staff and how professional and committed they are.
And Martin, do you think that is going to have a long-standing legacy, or when this is all over, are we going to revert back to how social carers were viewed before?
Well, Andy, I think it's our responsibility, all of us, but particularly people like me, to make sure that we don't slip back. I think we now have a platform, and we must use that platform for improvement. It must be about the long-term strategic improvements that we need in things like social care funding, but it must also be about recognising that we have got a very skilled and professional workforce, and we need to make sure that they're remunerated and acknowledged and recognised for the complex work they do and the tremendous skills they have. So I think in answer to your question, there is all to play for, and we must make sure that we don't slip back.
Well, look, Martin, you've raised frankly, it's been the burning question for the last 25 years that I've been looking at the care sector, funding and where that comes from and so on. Do you think that the pandemic has crystallized in the views of the power in the country that social care needs better, stronger funding, long-term funding structures? And if so, how do you think that will materialize?
Well, I think the pandemic has really put social care very much front and centre. I think politicians have acknowledged now the complexity of the work done in social care, and I don't think they had any understanding before this pandemic about the complex nature of the work people do, and also the high level of need there is in our sector to deliver care to people who have a range of different health and social care needs. So I think those things are now on the government's agenda. I really think as well that the government made its commitment before the pandemic to social care reform, and in a way there is no wriggle room for them, because the Prime Minister himself has committed to making sure that we do have social care reform. Of course, our challenge is to make sure that it is the right reform. And what we don't want is a bit of piecemeal tinkering at the edges. I think now is our moment when we've got to advocate for a new vision for social care, and also for a long-term and sustainable funding, which not only acknowledges the needs of the current system, but also enables us to invest in the future, not only in our staff, but also in things like the physical estate of social care, and also technology, which is going to be one of the big drivers of the future.
I'd like to come back to that point on technology, Martin, because I agree with you. I think that's a massive point for the future. But look, you've alluded to the green paper that we've all been waiting for. Now, frankly, successive governments have promised that there will be something coming out about integration of health and social care and making it work. If you were writing that, what would be your top priorities?
Well, I guess what I would do is I'd want to revision social care. So I'd want a new vision for social care and what it's about. I'd want also a really clear and long-term workforce strategy that not only links to what the qualifications and frameworks are for developing careers in social care, but I also want to see the money associated with giving people a proper reward for a highly skilled job. And then the third thing I would want is to look at how technology can transform social care. You make a really interesting point, because I would also want to see better integration between health and social care. But I want to reclaim the term integration, because so often people talk about it in terms of the NHS, care providers, local authorities. Now, in my view, that misses the point. True integration is how people experience services. Now, if you think about going on an aircraft, you arrive at an airport that's owned by one company, you go through into a lounge owned by another, you get on an aeroplane and you move through several international jurisdictions, but you don't know what's going on, because what you experience is a flight from A to B. So on that flight, I do not know when I leave Austrian airspace and go into German airspace, because there is a massive administrative process, but it's all going on so much in the background that what I experience is a flight that gets me from A to B. And that should be how we define the whole role of integration. And I don't want integration talked about in terms of organizations. I want it talked about in terms of outcomes and people's experience. And that is the holy grail of integration. We have a long way to go in order to get there. And we're going to have to see radical culture change, not structure change. You know, I've lived through many structural changes in this system. You know, I remember PCTs, I know CCGs, I remember joint commissioning, I remember joint appointments, and none of them had the desired effects of a seamless integrated system. So I think we've got to reclaim integration as being about the people who receive services and work in a way that makes their life as easy as possible.
I think that's really interesting, Martin. And actually, in the first lockdown, I was working on a deal for complex care in the home, so NHS provided, but also linked to local authority spend and so on. And it seemed to be that they were coming together and getting decisions made because they had to, and it wasn't, the bureaucracy wasn't getting in the way. Was that your experience as well? And can we take that forward?
Yeah, it certainly was my experience. And for example, there used to be a long and contorted process to get care providers onto Capacity Tracker when the government needed them on Capacity Tracker because they needed data and they wanted to find out how their extra money was being spent. Then all that administrative process was cut away and people were actually able to get on Capacity Tracker very quickly. And I've seen countless examples during this pandemic of things that used to be taking months, if not years, which are now happening immediately. And we have got to capitalize on that. We've got to stop the bureaucracy that is always the impediment to change, to delivery, to innovation. We've got to stop it in its tracks. We've proved in a crisis we don't need it. And we need to make sure that we've learned that lesson, all of us. And I think there are big messages from this pandemic. There are certainly messages for government. There are messages for commissioners. There are messages for providers. And one of those messages is stop making things difficult when they can be simple and they can be quick.
Yeah, yeah. No, look, I wholeheartedly agree with you on that. We've mentioned a couple of times technology and its place in both the current and the future of health and social care. Are there any particular innovations that you are seeing which you think will transform the way that we deliver care in the UK?
Well, I certainly think we're going to increasingly use technology to be proactive rather than reactive in our care. So, for example, many people who are watching this will be wearing a Fitbit, and it will tell them a whole raft of information about whether or not they've done so many miles or steps. Now, we can have Fitbits that will give us so many different parameters, so we can then be looking at very small changes in a person's condition, and we can then be proactive. So slight increases in temperature could be, for example, the precursor to things like a UTI. If we could put in proactive medicine, we could stop people going then into crisis and needing A&E treatment or having a hospital stay. So I think there will be a lot of those sorts of things. I think there will be also great strides in things like electronic care planning, which will make things easier, will reduce the amount of cost and administration burdens, will also provide really good audit trails for the regulator and real-time data. And I think one of our challenges is to make sure that we have a technologically empowered system that also produces the data we need to understand what's going on. And that data needs to be at an individual level, but it also needs to be at a macro level so that we can see how we plan and develop the system for the future.
It's very interesting. I think in the audience today, we have people from that technology background looking at things like care planning for individuals, but also using the data that comes from that en masse to then be able to, I guess, generate better outcomes for people in the future. So I wholeheartedly agree with that. The challenge of paying carers properly for the fantastic service they do has been an ongoing issue in the UK. Do you see any signs of that changing?
Yes, I do. And I'm really heartened by, for example, Jeremy Hunt, the chair of the Health Select Committee, calling for a 10-year workforce strategy in social care that should mirror the strategy in the NHS. And I think one of the things we should acknowledge as we move into the future, we are going to need more and more people in care and in health. And we cannot have a situation where people can't move between the two systems because there won't be enough people to manage things in the way that we manage them at the moment. So this revolutionary approach, which Jeremy Hunt is advocating for a workforce strategy that mirrors the health one, will also be about developing skills and competency frameworks that will enable people to work in both health and care. And the future will be about people who move seamlessly between two systems, just as citizens do. The same citizens who put that money in may find themselves in a hospital one day and a care home or in a domiciliary care support service the next day. So I don't think we should have this arbitrary division between the training of social care staff and the training of health staff.
Well, I've been working with care businesses, say, for 20 plus years. One of the challenges always has been from the regulator point of view.
But my view is as well, we need to take a much longer term view about regulation reform. And I think we need to move to a situation where, as we get more real time data, we use a lot of that to prove to regulators the quality of services and stop this, going in once a year or once every 3 years to do a regulatory inspection, which is an inspection on a day. So I think we should use data for more real-time analysis of where services are. I also think there is a real problem in the way in which we frame regulation, because at the moment what happens is we frame it in the basis of people coming in and saying this is what you did wrong and scapegoating the people who deliver the service. I much prefer the airline industry approach, which is to have a very critical analysis of incidents to identify what the causes were. Some of them will be systemic, some of them will be about individual action. But again, what the airline industry does is when it finds the cause, it then updates everybody's knowledge on that issue and it cascades it to the entire sector. And from that, we get service improvement. And so my view is that regulation should be as much about service improvement as it is about the sort of punitive nature of the current process, which singles people out but doesn't learn lessons which could be applicable across the whole system.
Given the audience we have today, where a lot of people are sort of private providers in the sector, looking at where to make their future investments in a sector that they passionately believe in and support, where do you think the big places for investment will be over the next few years?
Well, I think technology is obviously going to be the place where people can invest. But I also think care providers need to think about how they flex their model and how they reach out to new sources of income. So, for example, if I was a residential care provider, I might, for example, think about what services I could provide to people in the local community using my care home as a hub, making sure that if people wanted to use my services, I did the advocacy bit of getting them onto a direct payment so they had money in their pocket to buy those services. And I think in a way, lazy commissioning has led to people providing the same sorts of services. So I do think care providers need to look to where are the opportunities to differentiate themselves and to provide added value. I think we've got to find ways of developing a more innovative approach to things. Technology will help. And I think if you look as well, there will be some disruptors that come on the scene that may also help us change the model. So, if we have disruptors, just as the taxi system had the disruptor of Uber, that changed the world as far as the experiences of people who use services are concerned. And that will happen again in social care. So what I would say to social care leaders is get ahead of the curve, because change is inevitable and it can either be met with one or two responses. If you try and be like King Canute and resist it, it will overwhelm you. The better part of this is to lead the agenda and steer the change, and then you will be on the front foot.
My final sort of question is if I'm the fairy godmother with a magic wand, if you were to have sort of 1, 2, or 3 wishes about how you would see the change over the next couple of years happening, what would those absolute priorities be for you?
Well, I think they would be about a new vision for social care that works on people's assets, not their deficits. And that vision should include as well prevention, because what we have at the moment is a system that only responds when you're in a crisis. And actually, we all want people to be supported before they get into a crisis. So the new vision would be one thing. I want a new approach to the workforce. I want proper skills and competency frameworks. I want portable qualifications, and I want parity of esteem and also parity of remuneration with the NHS. So I think that is an area we need to work on. And then finally, I want a long-term and sustainable funding solution that enables care providers to think to the future and also gives them enough capacity to deliver high quality care now, but enough money to make it a worthwhile investment that will attract more money into the system which will then lead us to a 21st century care service, which is properly invested and properly rewarded and properly acknowledged by the whole of society.
Martin, I know that those views are very heartfelt from your point of view, but they are music to ears of all of the audience as well, where I think we all subscribe to that for the future. So, Martin, thank you very much for taking part in this event today. Look forward to speaking to you soon.
Thanks very much. I really enjoyed that, Andy.
Well, as you can see, I'm wearing different clothes. My shirt isn't hanging out, and actually in a different room. That was pre-recorded, but really interesting views from Martin Green. We've had a couple of questions and comments sort of coming in. I'm just going to pick on one of them, which talked about technology, and as the technology world matures, is it going to all end up in the hands of Apple and Google? And I think I'll probably throw that back onto you, the people who are running those businesses. What I hear is that some of those people who are trying to do those roll-ups are taking away some of the essence of the product that they had. I may mention names like Access, probably not quite providing what you really want. And I think there's a big opportunity at the moment to really demand the right service from those tech providers. The ones that I've been speaking to really relish the challenge of building on what their platforms are, working with care providers to produce the absolute best in class, best quality, best for the future. Now, will they eventually end up in the hands of Apple and Google? I don't know, but you can help shape them, I think. Our next speaker is Giles Johnson of CIL. Many of you will know Giles. He's worked on a lot of deals, and he's incredibly busy with the investment that's going into the healthcare marketplace at the moment, working with private equity investors and companies alike to review strategy and help the investors understand the businesses that they are investing into. I mentioned on that interview with Martin Green, a business that's funded partly by healthcare, partly by social care. It was a business called Bespoke Health and Social Care, and Giles led the due diligence on that project with us last year. So I'm going to move straight over now to Giles to share some views of how he's seeing some of those private equity investors looking at the marketplace at the moment, which I think will be quite topical for you, and how some of the trends will carry out over the next few years. Giles, over to you.
Hello, everybody. Hello to those that I know. Hello to those that I don't know. A bit like Andy, I think we probably both started out young, good looking, with a full head of hair before we started working in this industry and been at it for some time now. So I'm going to canter through just a little bit of an intro on CIL for those that don't know us, and then just some sort of industry musings, I suppose. Then as I understand it, there's a bit of a Q&A at the end. I would invite my hosts to make sure that I keep to time. I'm going to set the timer, and I think it's sort of 10 to 15 minutes for me, and then some Q&A afterwards. So this is CIL, won a few awards, 110 people, and then really we're focused on strategy consulting and commercial due diligence. And we work across a whole range of different sectors, one of which is healthcare, you can see here. We also do education, and sectors like special educational needs would sort of sit between the two. But the interesting thing here, when picking up on Martin's comments about technology, for example, or indeed another big trend that we see, which is the consumerization of healthcare, and I'm going to stray more into healthcare than social care there, is that a lot of these sectors are starting to work together, and skills from one get to be deployed in another. And I suppose one thing I would pick up on as an answer to that last question that Martin was answering, and that is go and look at other sectors and then come back to health and social care. There is a tendency, I think, in health and social care to grow up in the sector and sort of accept all the things that have always been so, need to continue to be so ad infinitum. So those are the sectors we cover. Here's what we do: investor support on the way in, so commercial diligence before you buy a business, growth strategy, helping you grow a business whilst you own it, and then exit planning, which is either sort of vendor assist work or vendor commercial diligence. I will get through the salesy bit quite quickly. Apologies for this. A whole bunch of private equity and infrastructure clients and banks and so on that we've worked for over the years. But the important one is this: the operators are the heroes of the sector. They're the guys that provide the service, deploy the capital, make sure the capital gets a return, etc. And you can see here a whole spread of things from, and I know there are sort of people from some of these businesses in the audience, but also there are a bunch of different sectors covered here, and I think all these sectors are covered by people in the audience. So there's product businesses here, Millbrook, and Countrywide Healthcare Supplies, etc. So supplies and equipment into the community, learning difficulties, adult care, so supported living and residential care, and then children's services as well, elderly care, the works. And there is a massive industry there. And I suppose what it does show is it's very easy to get investors into a conversation about investing in the sector, because there are so many different ways of deploying capital in here and of picking a subsector that you could be interested in. So that is the boring salesy bit out of the way. Hopefully this bit now is a bit interesting for everybody. So I thought what I'd start with is let's just sort of take a step back, and rather than dive straight in and start sort of start almost immediately failing to see the wood for the trees, let's step back and say what makes any industry attractive for money. And the Warren Buffetts and so on of this world will often use these sorts of things. This is a Porter's 5 Forces model. It actually it doesn't mention market growth, so I've added that in as an additional one. So it's the Johnson or CIL 6 Forces model, perhaps. But if you go round each of these inputs into the sort of analysis you might do on a sector to see if it's attractive, sort of sector you want to invest in, you can see that the health and social care sectors typically tick a lot of these boxes, but equally display some issues around some of these factors as well. Barriers to entry, for example, is a very interesting one. Traditionally been quite low. So it used to be really quite easy to set up a children's care home. In fact, there are still unregulated ones. An elderly care home. We're often property investors, not people out of the care industry. Very low entry barriers to entry for domiciliary care businesses, for example. Relatively easy to set those up, and it's been one of the issues around, is this a sector I want to consolidate in? I think some have gone a bit too quickly at it. However, this has changed. So the advent of technology, of CQC and Ofsted with regulation, the appearance of frameworks when it comes to selling into local authorities and local healthcare economies, CCGs, commissioning generally, and then increasingly now sort of Trustpilot, I want great care type websites and so on, where consumers are increasingly putting their opinions out there and so on. The barriers to entry are going up a lot, and this is one of the reasons why care markets have now become, I think, more attractive. Threat of substitutes is an interesting one. This is more around, I think, the transfer of emphasis between different modes of care. So out of hospital into the community, out of care homes into live-in care, and that's been one of the things that's happened in the pandemic. Out of care homes in children's services into fostering, and then maybe a bit of a swing back again. And the other thing around threat of substitutes, which we'll come on to in the next point, is also that the public sector itself is a provider as well as a commissioner. And there's this sort of substitution effect you can get there. So they used to provide care homes. Obviously, they do a certain amount of domiciliary care, but they do a lot of in the fostering market, for example. But that's something that's slowed right down. It's not a fast-moving sector in that sense. Market growth, we'll come on to. Underlying market trends are all positive. That's something that investors like. Bargaining power of buyers is interesting when they do have their own services. So if you're selling to local authorities and they're also providers, what sort of choice is there? The reality is, of course, local authorities tend not to provide a terribly good service themselves. So they tend not to be as sort of, well, it's one of these things that investors get concerned about. Am I selling to a single customer here, the government, the NHS? But actually, when you peel back the layers, often the buyers don't have anywhere near as much choice as one might think. Bargaining power of suppliers. I was going to hone in here on staffing. Now, the staff in care markets are not unionised, so they don't have collective bargaining, but they do have choice. And when unemployment was really low, staffing was a real problem in the sector, and that was eating away at margins, you know, combined with the rises in national living wage. So I think that's something to watch there. But there's relatively little supply chain power otherwise. And competitive intensity is another one. So these are the sorts of things that investors will look at in order to decide, do I put my capital into health, care, or other sectors? So let's just canter through some of the sort of some of the factors. Now, here is the government finances. You cannot talk about this sector without just checking in on the astronomical levels of debt that have been run up by the government, both in let me see here on my cursor, both in the global financial crisis, which we're bringing down quite nicely, and now the pandemic. So the government has huge amounts of debt, and this is one of the things that is effectively forcing their hand. This is why reform is very difficult. It's why pay rates are very difficult, attracting staff and effecting change in terms of that integration of health and social care that Martin talked about. These are all very, very difficult things to achieve when you're trying to spend less, but demand is going up. So we have trillions of debt now. It's practically the same debt pile as we make in GDP every year. Now, this didn't exist when I did economics at school. It's called quantitative easing, and it turns out the Bank of England can buy government bonds, put more money into circulation, and somehow it doesn't turn into inflation. As a result, interest rates can stay low, and that means that that extra 1%, the calculation you can see there, which would add 21 billion to interest payments on the sort of debts I've talked about on the previous page, don't necessarily come to pass. But what these levels of debt mean is that the government has to constantly talk about efficiency, cost cutting, and it cannot just write checks ad infinitum. There has to be some sense of a limit, I think. Now, I say that, I also question myself as I say it, because I never thought that these levels of debt and this level of quantitative easing would have really very little macroeconomic impact. So I guess they're caught between a sort of classical economic way of running an economy and this sort of tool that's now appeared. Given what we spent on the pandemic, it's fair to say, we should go back to the previous slide, it's fair to say, well, why not spend this money beforehand on actually reforming the health and social care system? But actually, I just don't know how well that would go down with the bond markets. What this all means is that effectively the sector has to ration what it does. Again, this is all slightly odd to talk about having just thrown tons of money at the pandemic, but I think the pandemic's just going to be treated as an isolated incident, effectively. You can see here, well, my conclusion here is that certain things are apples that have to fall off the cart, and the government cannot continue to just sort of absorb increasing demand ad infinitum. But what's interesting here is if you look at the wealth of those sort of younger age groups compared to those in the older age groups here. Now, it probably hasn't escaped your attention that the people who were 20 to 24 in 1970 are now the elderly in 2012-13 here, and they've basically taken their wealth with them as they've got older. What this means is that the government has to continue to look after them, can't take the money off them, but it has to be very careful about where it puts its health and social care pound. And it means that these sorts of things are having to effectively start to, I don't know, be restricted in terms of what's paid for on the state. And that's a lot of elderly care is now private pay. Low acuity care is an apple falling off the cart. Elective surgery, as you can imagine, is just sitting in a great big waiting list now. And new technologies that make life more efficient are very welcome. New technologies that actually mean we can now treat diseases that previously we couldn't treat from a healthcare economics perspective are less welcome. So One of the things that an investor will buy into is the underlying trend. This is the elderly market. If you take the population of those with learning difficulties, it's growing at 1 to 2% as well. And I'll come on to some trends in the children's services market around numbers of children who are looked after and numbers of children who require special educational needs attention. But there is a general sense amongst investors that these are growing markets, good, strong underlying growth tailwinds. Let's translate that into spend in this instance, adult community care. You can see the different care segments in the chart. We've got at the top there, supported living for people with learning difficulties, extra care in the middle. Then that slice one down, which is private elderly care. And you can see on the right-hand side that compound annual growth is starting to really outstrip what is the state-funded home care. And that's an example of transfer from public sector to private pound where that is possible. At the top, you've got the supported living chunk where clearly the customers, the service users, can't afford to pay for their own care, and that is where money's having to go, with that sort of accent on providing for people with high acuity. And you see this on the next page here, where we've got the rationing of home care. This is domiciliary care numbers. So the numbers of people in receipt of care is on its way down. The spend is pretty flat. You put the two together and you can see that the number of care hours going into those that are getting it is going up. So people are living longer and they're getting older for longer, and therefore those that need more care genuinely need it, and those that need a bit less are having to be thrown out onto their own resources. And this is a pattern you see throughout health and care markets. Let's look now just quickly at the impact of COVID on care homes, and one can see here a decline, quite a material decline in the occupancy in care homes. And what happened there was people were thrown out onto their own resources or into the home care market, and that has given, for example, private pay home care, particularly live-in, a boost in occupancy in the short term. But that's quite a material shift, and it'll be very interesting to see what happens next. You just don't know. I can't necessarily see that it's going to go back to where it was before. It all is really down to the home care market and what sort of slack it can pick up. Coming back to one of those factors that you would use to assess this industry and whether it qualifies as a good investment, and that is the protection that's provided and the barriers to entry that are provided by regulation. Now, this doesn't cover CQC and Ofsted. It does talk about the policy frameworks that have been coming down the chute. What's extraordinary about all of this is really, to Martin's point, really, how little difference this has made. However, I do think this last one, the white paper, Hancock's white paper, is going to make more of a difference than a number of the other initiatives have previously, because this is one of the areas, and I wasn't particularly pro-Brexit and didn't vote for it, but this is one of the areas where coming out of the European Union might well be a good thing. We no longer have to, or the government doesn't have to tender according to EU tendering laws. They can stick with providers that are doing perfectly well, don't necessarily need to re-tender things, and can put efficiency into that provider-commissioner relationship, stick with people who are doing a perfectly good job. What you can see here, though, is a sort of various attempts at reorganising things, lots of politics here, not much follow-up with money. And what is frustrating about the integrated care systems, which get another boost in the latest white paper, is that I think there are 40 or 50 of them. They are not coterminous with local authorities. And until they actually make, if you like, the local organisations coterminous across social care and healthcare, I can't really see integration happening in the way that we would all like it to. But regulation, generally, policy, lots to navigate there, and that's a nice barrier to entry. Local authority funding, as many of you will be aware, took an absolute hammering post the global financial crisis, and made life very difficult. Now, here we've got cash on the grey line, we've got real terms, so you put through inflation on the blue line, But what that ignores is the increase in demand. So if you were to overlay this with a per capita analysis, what's growth in pounds per qualifying service user, the line would actually go downwards. You can see there's lots of publicity around the funding gap here. But going back to my first point, in a sense, the government's got its hands in handcuffs. It can't throw too much money at this, or at least it doesn't think it can, in terms of the priorities it's got. Personally, why not cancel HS2 and spend money on this? I don't think they do get those priorities right. But when talking to bond markets, spending money on HS2 increases the country's productivity, they can argue. Whereas I think there's a general sense that throwing more money into social care doesn't increase the productivity of the nation, therefore there isn't a payback for those bondholders. So the local authority funding situation is what it is. I cannot see them hitting it with austerity in the way they have, but there isn't going to be a lot more money. Now, the good thing from an investment point of view is that means there's no capital for local authorities to build up their own provision in whichever sector you're in. So it means less competition, less crowding out from the public sector themselves. So a real positive there for being a private investor and building up provision and then commissioning. You're sort of handing that over effectively to the commission. Healthcare funding has always been a more attractive funding stream to be in. It grows more quickly, but of course, who knows what the hell happens next? And yeah, the budget in March really didn't mention much about the healthcare budget. I think they're still licking their wounds and working out what to do here. There is a massive waiting list. I think it'll continue to be the case that healthcare funding is seen as more attractive. Coming on to staffing. So unemployment has clearly ticked up quite. Sorry, I've got my eye on the time here. I'll canter through these. Unemployment's going up quite a lot and will come down. That's good for staffing in the sector. When we were down at sort of 3 to 4% back here, it was very, very difficult. And one can see here, looking at the various sectors, health and social care work is a sort of bright spot when it comes to where to find a job. This is the numbers of looked after children. So it's a growing population here. So investors will, should we say, give this a tick in the box. That's only up to 2019. Again, impact of the pandemic must be that these numbers are going to grow. I know that all the providers have seen very healthy demand here. Not great for society, but good for you if you're an operator. And then this is the number of children with special educational needs. And again, this is surely only going to go up as a result of the pandemic and homeschooling. And again, you can see here the independent sector taking share of the wider sector. And this sort of finally will be another thing that investors will look for, and that's an industry structure that looks rather like this. This happens to be the children's care market on the left, children residential homes, and then it's special schools, special educational needs schools on the right. And you can see sort of 70% of the provision is in small providers' hands, and that's a good opportunity to buy a platform and then buy and build your way into that. Not a lot of new capacities come on stream actually over the last few years. So yeah, it's the sort of industry structure that people would, investors would find attractive. So in summary, therefore, what are they looking for? Well, it's a form of, I think, when it comes to healthcare, social care, an equity income play. So deploy a good chunk of capital, ability to do follow-on capital, get capital growth, but also get growing profits and a good yield off the investment because of the quality profit streams. They absolutely want good governance and risk management, and that comes on to the next point, which is that goes to quality, which is not only good for business, occupancy and margins, but it's absolutely key to avoiding negative PR. And without going into them, you'll be aware of the odd story that has cropped up. Investors typically haven't really been burned by those sorts of stories, albeit I noticed the new owners of Thornbury Nursing got a shoeing, as Onyx did previously in the Sunday Times. Staffing always, I think, has a special place in the journalists' hearts for that sort of thing. But yeah, governance, risk management, quality all go together, and there's a defensive reason and a sort of good business growth reason there. Focus on high acuity, going back to the rationing point, or a city and county where you're driving the benefits of scale in becoming a really, really large domiciliary care business, and that just transfer power from the commissioner across to the supply side. And then you can invest in things like technology, which they are. So you're either showing the benefits of consolidation, or you're specialising in a sort of specialist high acuity service. Access to the private pound, wherever that's available. Home care would be a classic example, and access to healthcare funding streams where you can mix the two up between local authority and healthcare funding streams. So accessing quality funding streams where there's less downward pressure on margin, less of a cap. We get asked a lot of questions around staffing, and I think providers have to be increasingly careful here. So websites like Indeed will have a lot of information on them around what staff think about working at a particular provider. There are things like churn, agency usage. Good to do your own staff surveys. That means you can capture all staff feedback, and you're not just reliant on the sort of few perhaps who go on to Indeed, and they will look at staff pay as well. But staffing, I think, will continue to be an issue, albeit less so now unemployment's gone up. Martin mentioned technology. I would sort of expand that and say intellectual property. Some care businesses aren't reliant on technology, but they have particular methodologies that they deploy that make them good and defensive. And these are barriers to entry and sources of competitive advantage. And then the final thing is that long headroom for growth. So the ability to build out capacity organically, or indeed to do buy and build and bolt-ons and things to build the business and hand over, a growing story to the next owner. So I'm really sorry. I tried to stick to time, but I haven't quite. But anyway, that is the end of my presentation.
Giles, thank you very much. I knew it would be a challenging canter through everything to try and get that down. Laura, you've been sort of collating a few of the questions that we've had in from the audience. Would you like to ask a few of those for Giles?
Yes, great. And thanks, Giles. I thought it was fascinating hearing about the macroeconomic trends from somebody who sees all aspects of the care system. That's great. And also thank you to Martin when he recorded the interview with Andy. There's some great examples that he shared with us. Yes, I've been collating some questions from today, and also we've had some that have been submitted in advance. So can we start with the recent white paper that you mentioned briefly? And I know a key thing about that white paper back in February was about integration, and that was one of Martin's key points about true integration. I know I and some of our guests today loved Martin's comparison to the taking a flight from A to B and it being all about outcomes. What do you think the biggest changes will be going forward from this white paper?
I think the biggest change will be that no longer does European contracting law govern the churn of contracts from provider to provider. So if you've got a contract for 5 years and you've done perfectly well, the government may just say, do you know what, I'll give you another 5 and leave you. Whereas what that previously would have meant is the competitors would have kicked up a fuss over the extension and demanded a retender. It means that when they do award a contract, they're not so easily challenged using European contracting law. So I think there's a sort of great outbreak of common sense, I hope, there. I think it'll make it easier to become an embedded supplier. The issue will be, how do they actually continue to keep some competition in the system and have alternatives for when they do want to kick out a supplier and go to a new one? I think there's that. The other big thing will be the ICSs. Sorry, Andy.
No, I was just going to say, it feels to me that means that there is a demand for that supplier to invest in the service they're providing, and if they can demonstrate the quality is kept high, they can keep going. They can plan for a long term, which is at the moment you're on a 3-year contract. Yes, exactly. So it should lead to more partnership type working. So I think what that means is public sector and private sector working more in partnership together. Whether it's the sort of integration that Martin's talking about, where the healthcare system and the social care system work all together, I don't know. I've heard it so many times. I think it's incredibly difficult to do. But yet again, they've restructured the system and not made, whether they're CCGs or ICSs, it doesn't matter, but the building blocks of the healthcare system coterminous with the local authorities.
because then each local authority could work with one, I'll call them a CCG, and actually manage that local health and care economy as one thing. You've now got ICSs where there are 40 of them, so they'll be dealing with 3 different local authorities. Well, one local authority might like to do things this way, and another local authority wants to do things that way. What does the ICS, as it's going to be called, do? Mad, really. They didn't ask us to advise them.
Yeah,
seems like common sense. I don't know what you think.
we're waiting to see. Another question from the guests. You talked briefly about some pandemic trends, and to see really, in your view, whether you think they'll continue. We've seen a few trends in that. For example, the shift from hospital care to live-in care, and also from residential care to in-the-home care. Can you see those trends continuing?
I think they will. If you get a shift from, say, residential to home care, if the home care providers perform, i.e. provide a good product or service, then great, there's no reason why they shouldn't hold on to it. I guess it will swing back if they fail to do that. I think in the private pay sphere, they have on the whole provided a good service, and live-in tends to be privately funded. I think I think a certain degree of amount of it will be held on to. I don't know, who in the audience that sort of has elderly relatives, but I think there's going to be some reticence about going into a care home from here on in. And I think care homes therefore will become more like, there'll be more healthcare content in what they're doing. It'll be less of a sort of place to go and live. It'll be more somewhere where you go to get really more technology, more healthcare sort of built into the service. Which will probably shorten lengths of stay, ultimately.
Yeah,
there's
great.
more tech going into home care as well. It's just that home care you live in the home, whilst everybody sort of says more people want to be in the home, it can be a bit lonely. See anything, whereas care homes are more community of people.
That leads really nicely on to the next question. Martin talked about technology being the big driver over the next few years. In your work, have you seen some really good examples of technology working for the care sector? Is there anything that you'd put your own money behind?
Okay. I think the interesting tech in health and social care is often actually back office. So rostering, locum management, and so on. So bringing efficiency to the back office. In home care, iPads and care records that can be sort of administered in the home and obviously then throw data back into the centre and it can be used there. It's sensitive data though, so one has to be careful. But yeah, I guess the other place that one's seen it is the amazing shift to GP surgeries, GP surgery consultations being increasingly online and over the phone. And that has also gone through to outpatient consultations in secondary care as well. So I guess there's lots of tech in lots of interesting places. I think the back office stuff in these increasingly large care operator providers businesses is the interesting bit, actually. A bit boring perhaps though.
No, we're seeing meeting some really nice businesses with some great offerings that are really looking to the care sector to solve a problem. And work with the care sector to provide something that's really a really cracking product. And then I think we've probably got time for just one more question. And I was also going to ask you about the range of investors. We've in recent years we've seen the rise of infrastructure funds and REITs.
Yes.
And I was just wondering whether they're looking for something slightly different from the private equity investor.
Well, REITs I don't know so much about. They seem to sort of have their day about 7 or 8 years ago, and they sort of came into town and then went quieter. Infra I think is fascinating because what is core infra just clearly has not been performing during the pandemic. Airports, toll bridges, railways. So those that reached out and did this sort of rather funky healthcare stuff that was seen as a bit risky, the likes of Altan, AMP, under this sort of Core Plus banner, turned out to have made a really smart and relatively defensive move. Then the one issue there is that they will only invest in things that are asset backed. So it's got to be sort of property backed. So you won't, whether they'll go as far as sort of fostering and home care businesses, I don't know. It's sort of the next level on. I think ultimately they will go there actually, because they'll see that the quality of profit streams that you get in those businesses qualifies for an infrastructure type revenue stream. But the really interesting one is Icon, who invested in a business called Vanguard, which is mobile theatres. Now these can be moved around. They are commissioned on 3-month contracts. It's really not classical infrastructure at all. But they went for it, I think, enjoying a good yield. The business is, relatively speaking, a bit of a monopoly in that there aren't other businesses that do what they do in this country. So it's pretty unique in that sense. But they'll only go so far. They won't do the staffing businesses, the asset-light businesses yet. So there'll be a lot of space still for private equity.
Okay, great. Well, thank you. I'm really conscious of time, so thank you. If anyone has any further questions, I'm sure we can put those to our speakers at a later date. So do let us know if you do have anything that you've thought of since. So I'll pass back to Andy. So thank you very much, Giles.
Giles, thank you very much. That really leaves me to wrap up, to thank all of the audience for attending today, for some fantastic questions that we've received. We'll try and sort of address some of those. As I said at the start, let's hope next year we can physically get together at a proper event, shake hands, use some sanitizer afterwards, but move on into the new world. We will keep you in touch with what we're seeing going on in the market, please attend future events. So once again, thank you very much, Giles. I've already thanked Martin as well for his contribution, and Laura for asking the questions. And thank you for attending.